Today, we're going to look at a model of anesthesia delivery that is increasingly being adopted across the country, the all-CRNA model. There's a lot of misunderstanding and misinformation about it, so today we want to talk about it factually and honestly. When it works, why it works, and how it supports clinical excellence and autonomy. Whether you're a CRNA, an anesthesiologist, or a hospital administrator, this conversation will help illuminate how the all-CRNA model functions in a real-world practice. Welcome to Unmasked, the CCI Anesthesia podcast, the show where we dive deep into the world of anesthesia practice improvement, quality enhancement, and the evolving landscape of healthcare. I'm Doug Simpler, your guide on this journey as we explore the strategies, innovations, and stories that shape the future of anesthesia care. Get ready to be enlightened, inspired, and most importantly, unmasked as we unravel the many layers of the current state of anesthesia. This is Unmasked. Joining us today is Alex Gorecki, president of CCI Anesthesia. Alex brings over 25 years of senior-level experience in healthcare leadership, organizational development, and performance improvement. Throughout his career, he has supported leadership teams across more than 300 hospitals nationwide, with a focus on strategic growth, clinician engagement, and operational excellence. We're fortunate to have his strategic viewpoint in this discussion. Welcome back to Unmask, Alex.
Hey, Doug. Thanks for having me.
Joining Alex is Dr. Charlie Cochran, a board-certified anesthesiologist and vice president of medical affairs with CCI Anesthesia. Dr. Cochran is also the chief of anesthesia at Union Hospital in Terre Haute, Indiana, where he plays an active role on the medical executive, trauma, and OR governance committees. Dr. Cochran boasts a clinical background spanning cardiac anesthesia, trauma, and advanced regional techniques, and a track record of improving OR efficiency and preoperative pathways. Dr. Cochran, thank you for being here.
Thanks, Doug. Glad to be a part of this.
Let's set the stage. Alex, can you explain what an all-CRNA model is?
An all-CRNA model is where the CRNAs practice independently. They don't necessarily have anesthesiologists supervising them throughout the day. And so they tend to work at the top of their skill sets, and they manage their patient volumes and work as a team throughout the day to take care of patients.
Alex, when did CCI start advancing all-CRNA models, and why?
Well, we've been around for 22 years now, and since that time, we've had all-CRNA models, and that was driven in large part by the rural hospital market. Right now, if you look at the providers that are in anesthesia in the rural markets, 80% are CRNAs already, and then nationwide, 75% already practice independent from having anesthesiologists supervising them. And so it was driven by market need, a shortage of anesthesiologists too. Medicus Healthcare did a study, 56.9% of anesthesiologists are 55 or older at this point, and then 17% are close to retirement. And so you run those numbers out, by 2036, we'll be short about 6,300 anesthesiologists. And so if I'm going in for surgery, I need an anesthesiologist to do anesthesia, and there's none there, what are you supposed to do? You have a CRNA that comes in to compensate for that.
What misconceptions do hospital administrators and surgeons often have about an all-CRNA model?
It's generally the unknown. So a lot of these markets have never worked with CRNAs that are practicing at the top of their license. I came from a training program that didn't involve CRNAs at the time I was there. And when I went to the practice I was at now and worked alongside some really great independent CRNAs, I was impressed by the level of autonomy that they really performed at. And so until you kind of see it, sometimes I think that's the biggest misconception is you just don't know what you don't know. And you realize that the CRNAs that especially CCI hires are going to be at the top of their skill set. You know, these are the best of the best. These are people that want to be independent, want to practice at the top of their license. And so you match them in markets where there's not necessarily going to be an anesthesiologist that maybe wants to live there. And so, you know, a big misconception is, you know, where else are we going to fill these spots? There's just too many jobs out there, too much need for anesthesia, and not enough anesthesiologists to fill the roles that they traditionally did. It's the world we live in. And so I think, you know, the future is looking at how do we perform safe surgery in under-accessed areas. And the all-CRNA model solves a lot of the issues that have come up over the last few years with the decrease in access to anesthesiologists. There's simply no way around it.
Why do you feel this model is growing so rapidly nationwide?
Yeah, I think it goes back to access. You know, I mean, during the COVID, years, there's just a lot of anesthesiologists that retired, either during or shortly after. A lot of the concerns that anesthesiologists has are we going to lose access to jobs? And so far, the answer is by far no. I practice in the state of Indiana. If I want a job in any major city in Indiana, there's one available right now. My own practice is looking to expand, not decrease the number of anesthesiologists. There's still a market. There's still a role for anesthesiologists. But where we're talking about rural areas and under-resourced, practices, the need for CRNAs is growing. And we see that in the level of competition for good CRNAs, which I think CCI does a really good job of finding ways to attract these highly autonomous CRNAs. That need is there. And so I think the future is continuing to grow practices that are either all CRNAs or complemented by anesthesiologists in a way that both work at the top of their autonomy.
What could you tell a surgeon that might have some concerns about not working with another doctor?
Surgeons are always worried about, one, can I get my cases done? That's number one. Would you want to get your cases done? This market might require you to work with a CRNA. And that gets us 90% of the way there, I would say, most of the time, because surgeons want to operate. One of my goals as an anesthesiologist in my own practice has always been, how do I make the surgeon's life easier so they make my life easier? Okay, so first, if you just tell them, hey, CRNAs are access to doing cases. You like to do cases. Let's merge the two. And then the other 10% is always, well, what is my risk as a surgeon with a independent or mostly autonomous CRNA? And by and far, different states have different statutes, but the consistency is, as long as you don't actually direct their care, you have almost no legal risk of a CRNA practicing with you alongside you independently. That's the number one concern. In the state of Indiana, no surgeon has ever successfully been sued for anything that a CRNA has potentially done. That's just the bottom line. Does that alleviate all their concerns? No. But again, when you get back to access to care and very minimal risk legality-wise, I've always managed to get them all the way there. Our CRNAs in good old Terre Haute, Indiana, practice at the top of their license. They practice independently. We have anesthesiologists, obviously, that handle a lot of cases too. But there are nights, there are weekends that CRNAs are completely autonomous in our practice, and good things happen. Cases get done. Patients are well taken care of. It shows that CRNAs can practice independently and do a really good job when they do. And that's been my experience working alongside some really great people, especially during the CCI years.
Alex, what competencies make CRNA successful in an all CRNA model?
It's a very important question because not all CRNAs are created equal, right? And so when you're putting together an independent model like that, you have to look for CRNAs that are multifaceted. You can't have someone who's been working the past 20 years doing ophthalmology cases all day and expect them to go handle OB. You've got to have the right people. They can't be lacking in their skill sets for sure.
Wanting that autonomy is important. So you can take good CRNAs that really do not want to be independent, that they want the backup. And so I think a lot of it self-selects. I think a lot of CRNAs kind of know which direction they want to go. And I think having that drive to be efficient and independent is kind of an innate personality trait for a lot of people that, when you're looking to hire a CRNA for an all CRNA model, those are the kind of things I look for with just not skill set, but do you want to be efficient? Because you're probably going to be by yourself or with one other CRNA in a lot of these markets. We're talking 1 or 2 rooms a day that you have to get the pre-ops done, the post-ops done, get the cases through, get the turnovers done. And so it self-selects for very independent people anyway, because you're not going to have the resources of a level 1 trauma center. There's probably not 3, anesthesia assistants getting you stocked. You're probably going to be kind of on your own in an island, not only clinically, but non-clinically. And I think, knowing the type of people that thrive in that environment is really important as part of the interview process.
Dr. Cochran, what does an independent practice model look like for clinicians day to day?
As Alex said, you are the anesthesia provider. There is no cavalry coming. You have to be great clinically. You have to be willing to do the little things that maybe a bigger practice has resources that you don't, like with preoperative clearances, right? So, my practice has a great preoperative clinic. We got 10 nurses and 2 NPs, and we make sure cases are ready to go. In a smaller practice where we're running 2 rooms a day, you don't have those resources. So you're not only the anesthesia provider, you're the pre-op, internal medicine doc. You're the post-op rounding person. So you are taking care of these patients from the beginning idea of surgery all the way through the perioperative process, really independently. And so I think CCI does a really great job of setting resources in place for some of these smaller practices. While you may be on an island there day to day, you have the resources of what's now a very large anesthesia company, and that includes all the information, all the up-to-date things that make a practice well run.
If you're a strong CRNA working under a supervised model, it's not a big leap for you to go to an all CRNA practice because in reality, yes, you're supervised by the anesthesiologist, but you're already managing your own shop throughout the day. The anesthesiologist may be giving you breaks. They may be helping with pre-op. In terms of you doing your actual cases, if you're a really good CRNA, that anesthesiologist is not having to intervene in your day. And so for you to go from that type of model where you're already functioning fairly independently to a full-on independent all CRNA practice for a provider is not a huge leap necessarily.
How do CRNAs collaborate with surgeons, nurses, and the OR team?
Sure. I mean, it's important to get the day through, right? The collaboration starts in the perioperative process from the beginning of when a surgeon books the case for anesthesia, make sure that patient's ready to go that day. You're going to work with the OR director as well throughout the day to make sure the efficiencies are met. Our on-time start's reasonable. Are we showing up, getting cases done, getting them turned over, getting more cases done, and in making sure your OR's efficiency. So you're going to serve in roles in those sites that have a lot to say in how an OR functions. And so you're going to work with then obviously administrators to make sure that the anesthesia group is fulfilling what we need to do, contractually every day to make sure we're running the rooms we need to run and the times we need to run them. So you get a lot of outside clinical responsibilities if that's the kind of thing you're looking for to really have an impact on the way an OR functions and run day to day.
Dr. Cochran, what does the safety data show about how a CRNA-led model is different than maybe a medical-led or medical-directed model?
Yeah, absolutely. So while in big centers, there's always going to be a place for anesthesiologists. The data has shown that when we relaxed supervision requirements, particularly during the COVID years when there was really difficult access to care, that there was no statistical difference in outcomes between CRNA groups that had been relaxed and CRNA groups that had not. And so, that was the most recent study, but there had been studies 10, 20 years before that showed the same thing, that the outcomes are no statistically different, whether they're supervision models or CRNA autonomous models. So far, everything we know says that CRNA autonomous groups do really well in the way they treat patients and the way patients do.
What does a transition to this model look like?
Well, usually the biggest impediment, I guess, is the surgeons. Is that just either if they don't have experience working with CRNAs very much or working in an independent model like that. And that's where folks like Dr. Cochran and our regional medical officers come into play. They come in and as well as regional clinical officers, the CRNA leaders, to work with surgeons to help them understand how this model is going to look for them going forward and how it's going to be successful for them. There's always a bit of education that has to go with that and realize this isn't some major change. Like you're still going to be able to do all the cases you want to do. They're fully capable. And once you get over the hump of them getting to know the providers and getting comfortable, before you know it, they're totally fine with the CRNAs. There was one place in New Mexico where they had a orthopedic institute. And we recruited a bunch of anesthesiologists to go work at the Orthopedic Institute that was affiliated with the hospital. And those same surgeons were doing cases in the hospital and their Orthopedic Institute. And they finally were like, hey, we want our CRNAs to come over. We like the CRNAs that were used to working because they'd already been working with them before the Orthopedic Institute. And they're like, these are new guys. And they're like, yeah, but they're anesthesiologists. And they're like, yeah, but they're new guys. We want the guys that we know. And so we ended up transitioning more to a CRNA model over there as well, because they had gotten such a good comfort level with that team of CRNAs at that point. So it's just an education and then getting the experience with it.
I think Alex makes a great point. No matter CRNA physician, there's always the need for a great anesthesia provider. And so you'll see that CRNAs that practice independently and do really well are going to be successful in whatever model they choose. Same, there's always going to be a place for great physician leadership, for great physician involvement. But at the end of the day, we want people that are going to take really good care of patients. And as the evidence has shown and CCI's experience has shown, a lot of times CRNAs are more than capable of doing that.
Dr. Cochran, how do you manage resistance from transitioning to a model like this?
Well, I think it's about education. I think it's about familiarity again. People don't know what they don't know. And so the biggest key is these discussions take time. And so, when we're asked to come into a site and give an evaluation, or a hospital asks us to come in and say, hey, we're looking at this, and we've had a anesthesiologist position open for 2 years, we've never been able to fill it. We're looking to move to more of a CRNA model because, as Alex alluded to, there's a lack of access when these spots are unfilled. And so, when we start that process, I think it's important to start the process with the surgeons as well. I think, the hospital administrators from the financial aspect are always going to be a little bit more interested in a model that saves cost, right, and increases access. It's the surgeons that really, you have to start from the beginning of that process with the education, with the comfort level, with the backing of a large anesthesia group like CCI that says, these CRNAs here are going to be practicing independently, but they're not alone. And so, we have the resources to support a practice like that. And we do a really good job of it. That's something CCI has done for 22 years, and in a lot of these rural sites where access was the number one problem, CCI kind of got its start, in markets like that, and being creative with staffing so we could hire, like other companies are just now learning that, yeah, that works. And so I think just involving the surgeons from the beginning of the process is the best way to help, that comfort level as we make transitions in a model.
And having a strong chief CRNA is critical as well. Remember, we're not just throwing a bunch of CRNAs in there and they're just doing their own thing. Somebody's in charge of that team. And if you have a strong chief CRNA that's working closely with the OR director, as well as the chief of surgery, they become colleagues at that point. I mean, we routinely, as a company, we have leadership meetings. We bring all of our chief anesthesiologists and chief CRNAs together for a meeting. They're all in this big room together. There's 100 of them or so. You can't tell who's a doc and who's a CRNA in there because they're all colleagues working. They're all leaders. They all run their own departments and their own teams. And so having a strong chief CRNA in there who can listen to the surgeons and their needs, but also come up with solutions too, because not everything can be solved, right? Sometimes I know you want that, doctor, but we can't do it that way. This is what has to happen just because resources are limited or whatever. They'll say, I want 2 flip rooms all day just for me. And we're like, we don't have enough people to give you 2 rooms just for yourself all day, just so you can leave by 11 o'clock in the morning. It's not going to work. But so you have to have diplomacy. You have to have interpersonal skills to manage your team of people, because sometimes, this person said something behind my back and I'm upset about it. They don't teach you that in CRNA school or medical school or whatever, how to deal with those situations. And so our folks, our chief CRNAs, they have regional clinical officers that are CRNAs kind of at a regional level that help them out. We have regional directors of operations that are on the business side that help them out as well and give them additional resources to be good leaders. But you got to have somebody in charge of that anesthesia team to make an all CRNA model truly successful.
If your hospital is exploring ways to improve anesthesia coverage, reduce staffing vulnerabilities, and increase OR efficiency, CCI Anesthesia is a national leader in all CRNA practice models. We've successfully implemented and supported CRNA-led solutions in hospitals across the country with exceptional clinical outcomes, high provider satisfaction, and predictable staffing stability. If you want to explore whether this model could work for your facility, visit ccianesthesia.com to start the conversation. Autonomy and satisfaction are key metrics for recruiting and retaining best-in-class clinicians. Dr. Cochran, what type of clinician thrives at CCI?
Well, I think the great thing about CCI is we really have a place for about anybody. Since this discussion's about typically, some of the more autonomous CRNA practices, you want somebody that wants to be independent. You want somebody that wants to be at the top of their license. And so that drive is very important. And that's kind of an innate personality trait that usually can pick up on somebody. There are people that just really want to be out on their own. And they find these small practices that, maybe are only a room or 2 a day, but that they are the person. They are the anesthesia provider there. There's no backup. And so some people just really enjoy that, being able to be very involved at all levels of the OR, whether it's not just as a clinical person, but as a leader. And so those kind of practices, CCI has many types of. And then we also have traditional practices that are mixed with anesthesiologists where people don't have to be that, because not everybody does, but maybe they're a great clinician, but just likes that support or just doesn't want to be the person that's always on, as some of these practices kind of tend to be. And so I think we do a great job of finding roles for really any person in CCI. If you're a CRNA that likes different models, we've probably got an option for you. We typically do either, an MD supervision model or like we've talked about, through this entire session, there's a lot of great opportunities out there for CRNAs that want to be truly independent in these practices.
And holding providers accountable is critical to the team. So most CRNAs are high performers, right? And if you're a high performing team, and we bring in somebody that's just a slacker, like that brings down the morale of the whole team, because like, why does that person get to show up at 7:30 when we're all here at 7? Or why do they get the short room every day or cutting out early? So you've got to have the right mix of people where it makes sense. People have to have equal ability to handle different cases too. You can't have, well, this person can only do these kind of cases, so we got to wait for that room to wind down so we can move that case over there because this person can't do those cases. No, that kills the efficiency. It upsets the surgeons, and the patients are having to wait on somebody because somebody else isn't able to do the cases that they should be capable of doing. And if they're not, okay, how do we build them up? And we have support mechanisms for that. Dr. Cochran can go out. We have our EVP of Medical Affairs, Dr. Schmutzler. He can go out. They can work, and our CRNA leadership can go out as well, and they can help develop those people a little bit more if they need that development. But you have to have the team that can really function cohesively and at the same level. Otherwise, it's hard to keep morale up and keep the efficiencies there.
And I think because CCI has always strived for those high performers, and who we hire and who we build a good team around, it self-selects for better clinicians, because we will build up people who need the help, but if it's not a good fit, there's no reason in making the entire team unhappy. And so I think we do a really good job of self-selecting for some of the best, because we hire well, we have great practices, and we hold people accountable to be that.
How does autonomy improve retention?
Well, if you have a good, strong, independent team of providers, that autonomy is what they want, right? They like to feel like they can do what they've been trained to do, top of their skill set, like we've talked about. And so some CRNAs, and that's nothing against them, they like a heavily directed model where the anesthesiologist is coming in, starting the case for them and doing all that sort of thing for them. Others are wired differently, and they don't want to do that kind of model. And it makes them insane to have somebody telling them what to do all day. Like, they want to be doing their own stuff. And so if you have a high-performing CRNA, they want to be autonomous. They want to be able to do. And if you can't provide that to them, they're just going to find somewhere else where they can do that. And so even if it's more money, sometimes the frustration outweighs the money sometimes, because they're like, I'm sick of coming to this place every day and having somebody tell me what to do, especially if it's a surgeon that's trying to boss you around and tell you what to do. You guys are partners in those cases, like I said before. And so you've got your own skill sets, you've got your own things that you look for as an anesthesia provider, that your own business you need to take care of. Let me do that. That's the mindset. Let me do what I'm trained to do.
And as an anesthesiologist, it allows working with highly autonomous CRNAs to focus on bigger problems and whether they're going to push 50 or 60 or propofol, right? Like, there's more important things that I can be worried about or thinking about than some of the little nuances of anesthesia that when we hire good independent CRNAs, then I don't have to worry about that. In our practice, we focus a lot of our time on cardiac. I don't want to be asking the CRNA about the little nuances of a pre-op, which they've been trained to do, and hopefully, if we've hired appropriately, are going to do at the top of their license, and that gives them satisfaction. At the same time, gives me the satisfaction to work the top of my license as well. And so it's a nice fit when that comes together.
What is the impact of autonomy on culture?
Well, I think, again, if we're looking for people that want to be, the autonomous top of their license clinicians that they can be, it self-selects for high performers. And I think that's something that CCI has always gotten right in their history, is if you hire the best, you just have less problems. And it doesn't matter if it's a clinical issue, a leadership issue. If you just find really good people who want to do really good work, you're going to have great outcomes, which is why we have such great site retention. Why in the market, when we get places, CCI does a really good job of hanging on to those sites because of the people we hire, because of the expectations we have. It self-selects, you hire the best and good things happen.
Alex, where do you think CRNA-led practice models will be in 10 years?
I think we're probably going to see them more at surgery centers. I think that especially when you have a startup at a surgery center, they're looking for a more cost-effective way to do it. And frankly, at a surgery center, they're not doing open hearts. They're not doing neurology things, some of the things that traditionally You would have anesthesiologists doing, though we've had clients where CRNAs are doing those cases as well. I mean, they can do most any case if they have the right training for it. But we're going to see that more. And then we're going to, I think we'll see more CRNA practice, or all CRNA practices start getting into the suburban areas. I think urban areas are going to be a bit more resistant, but I think you're going to see more independence within those practices, even if there's physician supervision at those bigger hospitals. I think they're going to start stretching the supervision more than they've had in the past, just again because of the lack of anesthesiologists out there, where they may have traditionally had a 1 to 2, 1 to 3 supervision. They're going to be transitioning more to 1 to 5, 1 to 6. And to do that kind of model, you have to have independent CRNAs that can really function on their own throughout the day.
Dr. Cochran, what innovations do you see that might strengthen an all CRNA model approach?
Well, I think you've got to leverage technology. It's like anything else. Luckily, our jobs are fairly safe because it's very hands-on. Anesthesia is. It'll always be very hands-on. But with the AI boom that we're experiencing, I think you're not being the best clinician you can be if you don't utilize some of those resources that are out there. I mean, I can't remember every little detail I ever learned in residency or medical school, but I can look it up quicker and more effectively these days than I ever been before. And so, sometimes the CRNA will ask me a question. I'll be like, I'm 90% sure I remember exactly what to do in this clinical scenario. But with the advent of AI, in 30 seconds, I can get a much more detailed response that maybe is a little more clear and a little more science background, so that we continue to practice at the top of our ability. And I think that the growth in technology is only going to augment that. It's still a hands-on specialty. It always will be. But leveraging the growth in technology these days to make sure every day you're making better choices for your patients, I think every good clinician is going to have to buy into that.
Alex, how does CCI plan to support CRNAs as autonomy continues to expand?
Well, we continue to grow and develop leaders within our practice that are CRNAs. We have many regional clinical officers. We have our vice president of clinical affairs, executive vice president of clinical affairs. We have multiple layers of growth opportunity for CRNA leaders within our company. And so having them in those critical roles gives CRNAs an even greater voice within our practice as we look at different models we can run, as we address concerns that surgeons might have or that hospital leaders might have about all CRNA practices. And it allows us to be a lot more innovative when it comes to creating models and changing or creating more variety in the case mix. Maybe in the past, this particular hospital only did a certain scope of cases because they felt like that's all they could do because we only have CRNAs. We can, well, yeah, you can do all kinds of stuff, and we can help you understand how to do that. And so our leadership, our CRNA leadership can come in there and help them broaden their case mix and do most anything they want to do at that point in these rural hospitals. So having leadership in key roles makes a huge difference because that's your advocate. A lot of our CRNA leaders are part of their associations, their officers in their associations, their board members in their associations, their state associations, as well as the national association that all the CRNAs are part of. And so having them as advocates within their associations and then taking that information down to the practice level too from the associations is key. I think it's important. We partner with a lot of national and state associations with CRNAs and having our folks very much involved. We're not just on the periphery so we can put the logo on our website or something. That's how so many groups love to just write a check and then put the logo on their website. That's marketing. No offense to the marketing people out there, but that's just marketing. Having involvement at the top levels within those organizations is critical, and that's what our leaders do. We expect that from them.
Dr. Cochran, what do administrators and surgeons and other doctors misunderstand most about CRNAs?
I think it's the unknown of what the CRNAs that want to function at the top of their license can do. I think, CRNAs have been practicing safely for decades now, but we're seeing the growth of the need for more providers in more areas to cover more surgeries. And the misconception that CRNAs are not capable of doing cases in the places where we're asked to come in for these models is just incorrect. I've worked alongside so many great CRNAs over the years that I was impressed with and that do provide excellent care at the top of their license. And really, all CRNA practices or CRNA and MD practices elevate everybody. So, autonomous CRNAs elevate the physicians to be even better. We want to do the high acuity cases in the tough areas. For these rural practices, CRNAs want to be autonomous. So I think there's a lot of opportunity for all specialties, for all fields to provide access to great care. And that's what we're looking to do.
Alex, what's the biggest opportunity ahead for CRNAs?
I think the sky's the limit for them. The market is there for them. They've already been in that market for a long time, especially in the rural markets, and they've proven themselves for sure. In rural healthcare, as we talked about, there is no safety net. You are anesthesia for that community, and that's a good way to grow up fast. If you're stuck in that situation, you've got to figure things out, and so they've demonstrated that they can operate independently and they can operate in tough situations. We're going to see more autonomy, more growth for them, and that's both due to clinical growth, and I guess a growing understanding of their clinical capabilities, but also just market factors that we've talked about. Sometimes you just have to deal with the market realities that you're in, and so how do you work within those constraints? And that's, I think, smart leaders out there, smart healthcare executives and hospital leaders, they understand that, and they have a lot of constraints. Anesthesia is just one of the many problems that they're dealing with right now. But understanding that constraint and how to best navigate through that is critical for them. And they lean on CCI to come in and help provide that solution for them. Make sure it's safe, make sure the surgeons are comfortable with it, and make sure it can be successful long term.
Well, thank you, Alex and Dr. Cochran, for being with us today and bringing some clarity to this subject.
It's my pleasure being here. Thanks for having me.
Thanks for having us on, Doug.
At the end of the day, the all-CRNA model succeeds when it's built on trust, competence, strong leadership, and a culture of collaboration. When those elements are in place, clinicians feel ownership, confidence, and professional pride, and patients receive excellent care. I hope this conversation added context to the discussion and maybe even changed a few assumptions. I'm Doug Simpler, and this has been Unmasked. Unmasked is brought to you by CCI Anesthesia, leaders in anesthesia services for over 20 years. Subscribe to Unmasked, the CCI Anesthesia podcast today, so you never miss an episode. For more resources and information, visit the CCI Anesthesia website at ccianesthesia.com. We look forward to having you with us next time as we continue to unveil the remarkable stories and innovations shaping the future of anesthesia care. Until then, stay curious, stay safe, stay informed, and we'll see you next time.